that are.
It's currently 74 degrees in Lower Manhattan. Next news at 10 o'clock. Breaking news as it happens on New York's only local news talk station, 710 WOR. I'm Kristen Mark.
The following is a paid program. WOR's airing of this program constitutes neither an endorsement of the products offered or the ideas expressed.
Welcome, everybody. It's the Radiosurgery Show with Dr. Gil Lederman, MD, New York's only Harvard-trained, triple board-certified radiation oncologist who brings you the latest cancer treatment news, interviewing world-renowned cancer experts, delving to special cases, and, of course, answering your questions. I'm Rob Redstone, broadcasting from the WOR studios in the heart of New York City. And now, please welcome Dr. Lederman.
Hello, this is Gil Lederman at the WOR studio. We're live, and we're thanking Noah and Mike in the control room. They're running this program. I want to dedicate this show to my son Ariel, who's out in Tucson studying hard. And we had a magnificent day in New York, so I hope that everyone's in a good mood. Had a lot of clean air, sunny skies, and good food today. We have blueberries and sweet corn in season, so it's healthy and tasty time of the year. We do take your calls if you have questions, so please feel free to call us. Our number is 800-321-0710, 800-321-0710. So if you have questions about health or cancer or treatment, if you think it's interesting or interesting to you, please give us a call. There's a lot of new news out there, and news that often is not seen in the typical media, and we're trying to dwell on that and dwell on information that may be of importance to people who are trying to get the best health care for themselves and their loved ones. One of the biggest topics in oncology is the fact that a lot of drugs are not available for patients, drugs that may cure cancer. So there's shortages of cancer drugs, and oncologists and hematologists are saying that there's suboptimal treatment because their patients can't get the drugs that they deserve. There was a survey at the ASCO meeting. The ASCO is the National Association of Chemotherapy Doctors, and thousands of people attend their meeting. There was a recent meeting this summer, and there was a survey conducted by the University of Pennsylvania of 214 oncologists, and 94% said their patients' treatments had been affected by drug shortages in 2012. 83% said they were unable to provide chemotherapy at some point during that time, and 13% said clinical trials had been compromised due to drugs that were not available. So it's a big issue, and if you're getting chemotherapy, you may want to ask your doctor, are drug shortages affecting my treatment? It's a relevant question. You want to know if you're getting the best drugs, or you're getting a substitute drug, or you're getting a less optimal drug for your cancer. One doctor, Dr. Seidman from New York, said that quality cancer care means providing patients with the right treatments at the right times. And we're learning today that cancer drug shortages are interfering with that mission. So it's a serious matter. Often there's no replacements for standard agents that have been shown to improve survival. So there's some compromises being done, and there's a lack of evidence that substitutes are equally good. So in the 2013 study of doctors, 40% said the drug shortages had not been resolved, and 17% said the shortages were worse than in 2012. 16% said they were the same, and 9% said they had improved, while others said it worsened. So it's a serious matter. I mean, the beautiful thing about radiation is that we produce our own cancer-killing agent, and not only do we produce it, but we deliver it. So we're able to give the right agent at the right time, focused on the tumor. So luckily for us, compared to chemotherapy, we don't have the issue of, are we compromising care? Are we compromising delivery of care to the patient? So please ask your doctor if you're getting through chemo or your loved ones are getting through chemo, am I getting the recommended dose of the recommended agent, or has there been a compromise due to these drug shortages? There's new news about glioblastomas. So glioblastomas are the most common primary brain cancer. So primary means that it starts in the brain, and cancer means that it can spread. Glioblastomas are known to be devastating often. They're one of the feared brain tumors. And there was a study that was done, a phase 3 study. So a phase 3 study means that there's two arms of the study. Arm number 1, which is usually the standard treatment, which is radiation and Temodar chemotherapy. And in this case, the other arm was radiation, Temodar, and Avastin. Now, Avastin is a biologic agent. It's been approved for recurrent glioblastomas, but it was never approved for primary treatment of glioblastomas, meaning the first treatment. So at the same ASCO meeting, there was a phase 3 RTOG, which is a radiation oncology group, that studied this. Bevacizumab, or Avastin, is a monoclonal antibody that's designed to stop the blood vessels that goes to the cancer. And so by blocking the blood vessel, the idea is that the cancer should shrink. Now, we're going to talk later about what should happen and what does happen. So I think for the patient, it's always interesting what's supposed to happen and what's the mechanism. But maybe the primary question is, does Avastin work as primary treatment for glioblastomas? So this study was a significant study. 637 patients with newly diagnosed glioblastomas were randomly allocated, either to have standard chemoradiation, which was Temodar radiation, or the second arm was chemoradiation plus Avastin. And they gave it intravenously every 2 weeks. And what happened? Well, the median overall survival in the Avastin arm was 15.7 months. And in the standard arm, it was 16 months. So a shocking result, but that's why studies are important. We should respect studies, and if a study is well done, honor that study, because in this case, the survival was less good in the new arm than the old arm. And so the standard of care right now is radiation and Temodar for glioblastomas when they're initially diagnosed. We in our center use very focused radiation called radiosurgery or focused treatment to try to minimize the harm to the healthy brain. So we really believe in trying to avoid unnecessary radiation as much as possible, and in the brain, obviously, that's important. So this is an important study for people with glioblastomas. That Temodar and radiation is superior to Temodar radiation and Avastin in newly diagnosed glioblastomas. We have a call from Lou in Harlem about diabetes. So hello, Lou.
Yes, hello, doctor.
How are you tonight?
I'm all right. I'm not full-blown diabetic. I'm borderline diabetic. But I've been reading on the Internet how beneficial cinnamon can be as far as regulating blood sugar. Are you familiar with that? Could you give me some advice on that?
Yeah, I got that question, and I would suggest you call me during the week. We're trying to dedicate this show to cancer and cancer treatment, so you can call me during the week at 212-CHOICES, and I'm happy to speak to you about that. And that's true for anyone in the audience. If you don't want to speak on the radio, please call me at the 212-CHOICES phone number. We had some interesting cases this week that I wanted to bring up and discuss with you. One was a woman who called me during the week, and she said, why don't you talk about my disease, which is meningiomas? So meningiomas are usually a benign brain tumor. They're a brain tumor that start from the meninges, which are the coverings of the brain. And a benign type is called a typical meningioma. They can become aggressive and be called an aggressive meningioma, or even malignant, which means it can be a cancer-like meningioma. So the one reason to treat the meningioma is to get rid of it and get it out of way so it doesn't grow and progress to a malignant meningioma, which may well be fatal. So this woman had a meningioma on her optic nerve. So the optic nerve is a nerve that goes from the brain to the eye. And she had symptoms from it. She's been following MRIs on an annual basis. She's seen many, many surgeons. She's aware that surgery may harm her vision or even take away her vision because the tumor is wrapped around this delicate nerve, and if the surgeon can't help it, he may harm that delicate nerve. So we spoke on the phone, and I told her she's due to get a new MRI in September. To get that new MRI and then look at all the MRIs. She can bring in all the MRIs, and we'll compare the newest one with the oldest one and the newest one with the most recent one, and look at the growth rate and look at her visual fields, which is how much of the world she can see out of that eye, and her visual acuity, and then make a decision. So with our treatment of fractionated radiosurgery, our success rate in stopping the tumor where we aim the beam is about 97%. So it's quite high and quite appealing, especially for someone like her who obviously does not want to have surgery, which would be major surgery, opening up her head, dissecting out the optic nerve and trying to remove the tumor without leaving any tumor cells behind, which is really, really tough to do. There's some other news in this week about cancer. One is cancer risk and height. So we don't often think about, do tall or short people have different cancer risks? So there's a study that was done of women, almost 21,000 postmenopausal women, and it showed that the taller a woman is, the greater her risk of cancer. And the cancers were significant cancers. They included breast cancer, colon cancer, skin cancer. It's a serious publication, and it was published in a journal called Cancer Epidemiology, Biomarkers, and Prevention. And the question is, of course, why? Why would taller people have a greater risk of cancer than shorter people? And there was only speculation. And one is that growth is due to hormones and growth factors, and maybe those growth factors and hormones stimulate cancer, so that's one possibility. It may be that taller people have bigger organs, so maybe the colon or the lung or the breast. The skin is obviously bigger on a taller person, so if a person has more of it, if they have more colon tissue or more breast tissue or more skin, then maybe that by itself puts them at a higher risk. So that's another theory. And there was in May a publication in the Journal of the National Cancer Institute that reported height differences in men and women, showing that both had a greater risk, even in organs that were not sex-specific, like the kidneys and the lungs. And that study looked at 65,000 men and women and showed that sex difference in height may explain a third to a half of men having excessive cancer risk compared to women. So men have more cancer than women, significantly more cancer, and taller people have more cancer than shorter people. Again, others possibilities included food, childhood nutrition, circulating proteins. So this study for women looked at 21,000 women, and they were analyzed over a 12-year period. And they found that for every 4 inches in height, there was a 13% increase in developing cancer. And for women, the most common cancers that were at an increased risk were kidney, rectum, thyroid, and blood cancers. And those cancers increased by 23 to 29% for every 4 inches. So it's a significant issue, and something that you may want to think about. If you're tall, you may want to say, wow, if I have a 25% more risk than other people, maybe I want to get worked up. And the workup for some of these things are possibilities of finding cancers before they cause harm. For example, the rectum, colonoscopy would be good. for a kidney to check and make sure there's not blood in the urine, or do an